Hello, folks. My name is Xander Wilms. I'm an R1 with Dalhousie's internal medicine program, and I'll be doing a talk on the approach to assessing a patient's volume status with integration of point-of-care ultrasound, or POCUS. I'll start by emphasizing that this is an introductory talk. By going through various cases, the purpose of this talk is to provide viewers with the basics of how one can integrate bedside ultrasound into your practice when trying to determine a patient's volume status, instead of relying solely on the ever-evasive JVP. I'll also discuss a basic approach to management in these cases. Finally, I may mention some more advanced techniques that can be employed for evaluating volume status, with links to talks that are dedicated to those topics. However, I won't go into too much depth here. Let's get started. I have no disclosures. We're going to keep this talk as clinically oriented as we can, so after a brief introduction, we'll go through 3 very real clinical cases and cover topics as they relate to these scenarios. When approaching a patient's volume status, I use the words volume assessment and not volume examination deliberately. This is great advice I got from a former mentor of mine. You should really approach volume status as a holistic assessment, integrating multiple findings from all the clinical tools at your disposal. This talk will focus on the integration of POCUS into our approach, but the concept of assessing patients holistically is important to keep in mind whenever you are trying to decipher volume status. This elegant illustration from a paper by Dr. Cortella and colleagues illustrates how one can use multi-organ POCUS to assess a patient presenting with AKI. As we all know, volume status and kidney function are closely linked. I'll refer back to this group throughout the talk as they've created a number of amazing resources on clinical point-of-care ultrasonography. The diagram and the paper itself provide a useful framework to use when integrating clinical findings with POCUS assessment, and certainly is a highly recommended read for those who are interested. As previously discussed, the volume assessment, and by extension, the focused physical exam, can be difficult to perform and interpret accurately. Findings on physical exam and investigations can certainly help, including those listed here, but in this talk, we'll focus on integrating POCUS into that assessment. The authors in the previously mentioned article argue that multi-organ POCUS allows one to assess the hemodynamic circuitry holistically, including the pump or the heart, the pipes or the vasculature, such as the IVC and the JVP, as well as any leaks, including looking for pulmonary edema, pleural effusions, and ascites. A comprehensive volume assessment will allow us to answer key clinical questions that will influence our management of patients. The first question we want to answer is, will it be safe to administer fluids? While this may seem intuitive, IV fluids are administered every day without really considering this question. Of course, giving any intervention without ensuring it is safe to do so would defeat the purpose of what we aim to do as physicians. Second, we can try to answer whether or not fluids would increase the cardiac output and help to optimize our cardiovascular dynamics. Lastly, we should try to answer whether or not there is organ congestion, and in turn, whether diuretics would be more beneficial for a particular patient. All right, so now we'll dive into the cases, and I'll supplement these with some teaching along the way. We'll start with 2 relatively straightforward cases and focus on teaching around interpreting ultrasound findings. Then we'll finish with a more challenging case. The first patient here is a 57-year-old male in the emergency department presenting with dyspnea. He nurses progressive weight gain, orthopnea, and shortness of breath on exertion, but denies P&D, chest pain, or syncope on history. On exam, the pertinent findings are that he is vitally stable on 2 liters of oxygen, has a mildly elevated JVP, 2+ pitting edema to the distal shins bilaterally, and bibasal crackles to the lungs on auscultation. So the question is, what do you do? And of course, for the purposes of this talk, the answer is that we reach for our trusty ultrasound. The first thing we'll do is look at the lungs. Here is a quick refresher on an approach to lung ultrasound, with graphics from the same group of researchers mentioned previously. Generally, we use either the curvilinear or phased array probe when assessing the lungs, with the patient in a supine position. The probe is placed parallel to the patient's chest, perpendicular to the ribs in each of the lung zones illustrated in the slide. Once positioned, the clinician fans the probe to assess the lung parenchyma. Listed here are some of the findings we'll be looking for, and we'll discuss these shortly. For a more dedicated resource on an approach to lung ultrasound, there's a link to a Western Sono video coming from the ultrasound community at Western University. First, we'll focus on the patient's hyperechoic line here. On ultrasound, this represents the pleural line, made up of the parietal and the visceral pleura. When looking at this line, we're assessing for something called lung sliding, which is often described as ants on a log. As you can see, this phenomenon presents as a shimmering, hyperechoic line. This represents an intact pleural space, with the visceral and parietal pleura sliding along one another. When interpreted correctly, this rules out the presence of a pneumothorax. As such, this patient does not have a pneumothorax. The next thing we'll look at is the patient's B lines. These are defined as hyperechoic lines that extend from the pleural line to the most distal aspect of the ultrasound field without fading or becoming obstructed. B lines represent reduced alveolar air content due to interstitial pathology. Importantly, B lines are not definitively cardiogenic pulmonary edema, but have a broad differential diagnosis as listed at the bottom of the slide. Seeing 2 or more B lines in one ultrasound field indicates that there is some sort of interstitial pathology and that your findings are true. Seeing 2 or more positive zones, referring to the lung zones in the previously mentioned slide, indicates diffuse interstitial pathology. When encountering diffuse pathology, your differential diagnosis is more likely to include processes that affect larger areas of the lungs, such as cardiogenic pulmonary edema, ARDS, or interstitial lung disease. In cases where B lines are identified in a more focal area of the lungs, such as in one lung zone, this is more likely to represent a process such as a consolidating focal pneumonia or a lung contusion. The last thing we'll look at on lung ultrasound for this patient is for pleural effusions. These are best identified in the 4th lung zone on the diagram shown here. Pleural effusions appear as hypoechoic space enclosed by the surrounding structures of the chest wall, the diaphragm, and the lung parenchyma. Things to look for include the whale tail sign, which is represented by the edge of the lung floating in the effusion fluid. Another one to look for is the spine sign, a hyperechoic structure at the distal end of the ultrasound view. This is indeed the vertebral spine, which can be seen in this situation because the effusion fluid provides a conductive medium for the ultrasound waves to penetrate further than they would through regular lung parenchyma. The differential diagnosis for effusions is broad. However, it's clear for this patient that they have bilateral simple effusions that are more likely transitive, as we'll discuss when we discuss the diagnosis for this case. Finally, the data cited at the bottom of the slide has indicated that identification of effusions on ultrasound is more specific and sensitive than on physical examination or chest X-ray. Here is a brief refresher on the approach to cardiac ultrasound. Of course, we use the cardiac, also known as the phased array probe, with the landmarks for the 4 standard views depicted by, once again, Dr. Cortella and his colleagues in the image here. Here's also a textbook reference and a link to a dedicated video on cardiac ultrasound by an ultrasound group at the University of Toronto. These resources go into more detail on cardiac ultrasound and assessing left ventricular systolic function. Here, we are looking at the apical 4-chamber view of our patient's heart. Now, at the bedside, we really don't need to come up with exact metrics as to how the heart is functioning. The most important thing as a clinician at the bedside is to gauge grossly how the heart is functioning. Hopefully, we can all see here that our patient's heart is significantly hypodynamic with reduced contractility. This is what would be causing the congestion and edema that we picked up on exam and bedside ultrasound of the lungs so far. Finally, we'll assess this patient's inferior vena cava. To do this, we use the phased array probe once again. Once you obtain the cardiac subxiphoid view of the heart, simply rotate the probe 90 degrees so that the probe marker is pointed to the head. For a more thorough instructive video on assessing the IVC, here's a link to a resource by Dr. Simard at the Sunnybrook Health Sciences Center in Toronto. In our patient, the IVC appears to be quite dilated as it feeds into the right atrium. So in cardiac and IVC assessment of this patient, we see obvious hypokinesis and severe systolic dysfunction with a dilated IVC. A dilated IVC on ultrasound is defined as having a diameter greater than 2 centimeters with less than 50% collapsibility when the patient takes a sharp sniff inhale. This diameter is measured approximately 2 centimeters from the IVC right atrial junction. When one of these two findings are positive, the right atrial pressure is estimated at about 8 millimeters of mercury. When both findings are positive, the right atrial pressure is significantly elevated at an estimated 15 millimeters of mercury. In this case, both findings are positive and the right atrial pressure is significantly elevated. So it may have been clinically obvious, even without POCUS, that this patient is presenting in decompensated heart failure. However, what the POCUS provides us is risk stratification and prognostic information based on the appearance of the patient's severe biventricular systolic dysfunction. He's quite high risk and ultimately required urgent admission with expedited workup and management. To simplify our initial approach to management in this case, the patient is obviously volume overloaded, but hemodynamically stable. It would likely be unsafe to administer IV fluids. In order to try to get as much fluid off as possible, we will try diuresis and uptitrate as needed. Finally, we would want to trial diuresis prior to attempting a thoracentesis or drain of his pleural effusions, but this can be done for symptomatic relief in certain patient populations with the knowledge that you're not treating the underlying problem. All right, so case 2 is a female who's presenting to the emergency department as well, but this time with abdominal pain. She endorses weight loss, diarrhea, reduced appetite, and PO intake in the absence of sweats, chills, or rigors. Her physical exam shows that she's mildly tachycardic with a bit of a lower blood pressure and a fever. She has dry mucous membranes and a delayed cap refill. You do a quick abdominal ultrasound on her at the bedside, which is normal. So we'll try to answer the same basic management questions here after pulling out our ultrasound. We'll once again start with the lungs, and here we're looking at something called A-lines. A-lines are approximately equidistant hyperechoic lines that run parallel to your probe. They represent reverberation artifact due to air in the alveoli, with or without other pathological processes. Looking next at the peristernal long axis of the heart, we can see the walls of the left ventricle touching with each contraction. The heart appears to be working quite hard to beat in this case. We see this also in the peristernal short axis view, with the ventricular walls concentrically contracting almost completely inwards with each beat. These findings represent a hyperdynamic left ventricle. Importantly, you should adjust your probe positioning to make sure you are not foreshortening your view of the heart. A foreshortened view of a typically functioning heart can mimic the findings of a truly hyperdynamic heart and skew your interpretation. These concepts are covered in more depth in the previously mentioned resources for cardiac ultrasound. The differential diagnosis is relatively broad here as well, but is commonly seen in intravascularly volume-depleted states such as hypovolemia and sepsis. As you may know, in severe hypovolemia, patients will often present as clinically quite dry with a history of significant volume losses and/or reduced PO intake. On the other hand, sepsis is a distributive process whereby infectious-driven cytotoxic damage to blood vessels causes extravasation of fluid into interstitial spaces and thus results in distributive shock. Next, we look at the patient's IVC, which here doesn't look quite as plump as our last patient. In fact, this IVC looks quite collapsed. Given that the IVC drains into the right atrium, a collapsed IVC estimates a low to normal right atrial pressure at approximately 3 millimeters of mercury. A collapsible IVC is defined as less than 2 centimeters in diameter, measured 2 centimeters from the IVC right atrial junction. The IVC will generally collapse more than 50% on sniff test in these patients. In this clinical context, integration of our previous findings with the IVC would indicate that this patient is likely intravascularly deplete. And so, another relatively straightforward case. But what should we do for this patient? Certainly, based on our volume assessment, the patient presents as dry, and giving the patient IV fluids would likely improve cardiac output. So we'll do that. Of course, we're giving volume back, so we don't need to take any out. This patient doesn't need diuresis or drainage. Our final case is a bit more challenging. This patient is a 71-year-old male who's an inpatient. He has a prolonged admission and for the past 1 to 2 weeks has had reduced PO intake due to complaints of odynophagia. He has gross anasarca to all 4 extremities and appears warm and wet. His baseline creatinine is 60, which was elevated to 130 on admission. Because of his increasing creatinine, he was trialed on IV fluids, but he continues to be oliguric with a creatinine now at 160. Subsequently, his care team backpedals a little bit. They decide now to trial him on Lasix instead of IV fluids. As we all know, this happens a bit more commonly than we might expect. In any case, the patient has now been given 60 milligrams of IV Lasix yesterday after his initial trial of fluids, and his ins and outs are being monitored with a Foley catheter. After giving the dose of Lasix, his creatinine has continued to rise. His urine output was still minimal overnight, and he has a net positive fluid balance. And so, you're consulted for this AKI. So the question, as always, is what do you do? IV fluids didn't help. Lasix didn't help. But of course, your first step is to pull out your ultrasound and complete a holistic assessment of the patient prior to making further decisions. In this patient, you start on the heart. This is a parasternal long-axis view of the patient's heart. Looking here, the right ventricle looks quite enlarged in this image. Generally speaking, the ratio of right ventricle to aorta to left atrium should approximately be 1 to 1 to 1 in a typically physiological state. As we can see, this ratio is not 1 to 1 to 1, and the right ventricle appears enlarged in this case. Here is a short axis view, focusing on the left ventricular chamber. Here, we may be able to see the beginnings of what is known as a D sign, whereby an overloaded right ventricle pushes on the interventricular septum, thus flattening its shape. The flattened septum and the left ventricular wall form the shape of a D, as shown here. And finally, here is the apical four-chamber view. Here, you may be confused as to what you're looking at. You may even think the image is flipped. However, you are in fact seeing a grossly enlarged right ventricle that is encroaching on the left ventricle. The way you can confirm your orientation on bedside ultrasound is by identifying the moderator band, which is within the right ventricle, and also by visualizing that the tricuspid annulus is closer to the probe than the mitral annulus. So, based on our cardiac views, we can interpret right ventricular hypokinesis with biatrial enlargement. From this, we can ascertain that the patient's right heart is not pumping the way we would expect a healthy heart to, and that this is leading to backup of the fluid and dilation of the atria. On assessment of the IVC, we gather the same findings as our first case, whereby the IVC is quite distended and does not collapse to 50% on sniff test. This is a bit more of an advanced concept, but we will touch on it briefly here. Remember how we mentioned at the start of the presentation that our volume assessment can answer whether or not there is organ congestion? While we assessed the lungs and the heart for congestion previously, we will now use a different ultrasound modality to assess congestion in the liver and the kidneys. This image shows a combination of possible findings when assessing a patient's hepatic vein, portal vein, and intrarenal vein using Doppler ultrasound. These findings can be used to calculate a VEXUS score, and is discussed more in depth by once again the talented group that we keep referring back to in Dr. Cortala and his colleagues. You can find that reference at the bottom of the slide. While this is an entire topic in and of itself, the main thing I want to highlight here is that by assessing venous flow dynamics on ultrasound, one can more accurately determine whether a patient is congested or quote-unquote overloaded. As a pattern shifts from what we see on the bottom line here to that of the top line, patients are likely to be more congested, which can be assessed in combination with your other clinical findings. In the top left corner of the screen, there's another video link from the Western Sono Ultrasound Group at Western University on how to more rigorously apply the VEXUS technique. In short, these maneuvers are evaluating the degree of venous pulsatility and retrograde flow, which is so closely linked to right atrial pressure, which we would expect to become more elevated in a congested state. In this paper, the authors even make recommendations on diuretic therapy choice in the context of the findings here. Once again, this article is a great read and I highly recommend you check it out. So, in our patient, on assessment of the hepatic vein on Doppler ultrasound, we see an absence of these so-called S waves shown here, which is one of the waveforms representing anterograde flow, or blood flow towards the heart. The findings we see in this patient are similar to that of the congested patient described by the authors in the article we just discussed, where there are no S waves and only D waves present. Next, on assessment of the portal vein, we see a pulsatile flow. While there isn't obvious flow reversal, as depicted by the arrows in the image from the article by the pulsations of flow below the x-axis, the flow is still not continuous, but rather is pulsatile. This is also in keeping with a patient who is congested, as we can see in the diagram on the left from the previously mentioned article. So what do? The patient was first given fluids, but then given IV Lasix because they looked congested. However, their serum creatinine climbed and they continued to be oliguric. That being said, on ultrasound assessment, the patient still appears congested. As a result, you decide to stick to it and you continue with the Lasix. Just because the creatinine climbed with Lasix doesn't mean it's now time to give fluids. If the patient is clearly volume overloaded, you have to ask yourself if this is a failure of the actual treatment or just a patient that was being underdosed. The resolution of this very real case is that the patient's IV Lasix was sequentially up-titrated with assessment of response daily. The patient ended up requiring 160 milligrams of IV Lasix 3 times a day with metolazone before he adequately diuresed. Thereafter, the creatinine clearance improved over the following days. Ultimately, this patient was suffering from a type 1 cardiorenal syndrome with acute renal insufficiency secondary to heart failure. The pathophysiology of cardiorenal syndrome is complex. The most important concept that relates to this case, however, is that the patient's heart failure resulted in elevated central venous pressure. This causes reduced renal perfusion pressure and, with a dilated, poorly contracting right ventricle, can also result in impaired left ventricular filling, further exacerbating renal perfusion and functioning. To round out this talk, here's one of the first slides we looked at, and while this talk focused on bedside ultrasound, this is a reminder to approach volume status as a holistic clinical assessment. This is a final look at the diagram we referred to initially. Throughout the 3 cases, we've used many of the strategies referred to here to assess our patient's hemodynamics through multi-organ ultrasound. This is a reminder as to how many parameters can be assessed in patients with training in the visualization and interpretation of POCUS imaging. And finally, a couple take-home points. Remember to integrate all of the clinical tools at your disposal to fully assess volume status. Multi-organ POCUS can be used to holistically assess patients' hemodynamics by assessing their pump, pipes, and leaks. POCUS can help to confirm or contradict preliminary diagnoses, such as patients who appear volume overloaded and may or may not be in heart failure. POCUS can help to prognosticate acute patients and inform your plan, such as the first case who was found to be in new, severe heart failure and required expedited care. And finally, integrating POCUS into daily assessment of patients can inform the effectiveness of inpatient treatments and guide clinical decisions such as up-titrating diuretics in the third case. These are the references used throughout the presentation. Thanks so much for tuning in. Thanks to Dr. Ziren Meng, head of the POCUS curriculum at Dalhousie University, as well as Dr. Alan Tran for their support and contributions to this presentation. Please feel free to send any questions or feedback to my email here.